Welcome back, learner, to another deep dive. When most of us think about undergoing major surgery, specifically like the removal of an organ,
Right.
we tend to view the operating room as, well, the period at the end of a very long, very stressful sentence.
Oh, absolutely. We are totally culturally conditioned to view surgery as this, definitive finish line.
Yeah.
Like it's a structural reset that just instantly solves the biological problem.
But today, we're exploring a specific part of human anatomy that proves surgical intervention is, sometimes it's more of a comma than a period.
I love that way of putting it.
Thanks. We are looking at a highly targeted, often completely misunderstood structure, which is the vaginal cuff.
And for those of you listening who might think, well, this topic doesn't apply to me because I haven't had a hysterectomy, stick with us.
Yeah, please do.
Because this isn't just some niche overview of a single procedure. I mean, it is a profound masterclass in biomechanics.
It really is.
It shows how deeply interconnected our internal architecture is, and how one incredibly subtle subjective symptom like tenderness can just rewrite an entire medical protocol.
Right. And to map all of this out, we've pulled together a massive stack of sources today. We are drawing from clinical guidelines published by the Royal College of Obstetricians and Gynecologists.
RCOG.
Exactly. As well as protocols from NICE in the UK. Plus, we're integrating patient outcome data from the Cleveland Clinic and some highly specialized pelvic floor physical therapy guides.
It's a really well-rounded stack.
It is. And our mission for this deep dive is to uncover the hidden architecture of the pelvic floor after a hysterectomy. But more specifically, we are zeroing in on one crucial question.
Which is?
Does vaginal cuff tenderness actually affect the choice of medical treatment?
It is such a brilliant question to frame this whole discussion around. Because tenderness, it's entirely subjective.
Right, you can't just see it.
Exactly. It doesn't show up on a standard MRI or a CT scan. It literally requires the clinician to listen and the patient to actively report what they are feeling.
Yeah, which is kind of rare in modern diagnostics.
Very true.
Yeah.
Yet, as we'll uncover, that single, quiet signal of localized pain acts as a massive fork in the road. It completely alters whether a patient gets physical therapy, chemical treatments, antibiotics, or like a totally different reconstructive surgery.
Okay, so let's lay the groundwork. Before we can understand how tenderness dictates the treatment, we have to visualize what it is we're actually treating.
Right, the anatomy.
Yeah. So when a patient has a total hysterectomy, both the uterus and the cervix are removed. So if you imagine the pelvic cavity as a tent, the uterus and cervix are basically the center pole.
That's a great analogy.
And when you pull that center pole out, you can't just leave a gaping hole in the canvas, right?
No, definitely not. You'd have a serious problem.
So the surgeon has to fold the top edges together and stitch them securely so the internal structure is sealed off from the abdominal cavity above it. And that stitched closure at the top of the vagina, right where the cervix used to be, that is the vaginal cuff.
You are fundamentally creating a brand new anatomical ceiling.
Mm.
And even when that initial surgery goes perfectly, the biomechanical aftermath is, well, it's highly complex.
How so?
Well, the sources highlight this fascinating study tracking 242 women who had a hysterectomy for benign reasons. So things like severe fibroids or endometriosis.
Okay.
And the data showed that while overall pelvic floor symptoms usually improved, complete relief was absolutely not universal.
See, and I think that's where a lot of people get confused.
Yeah.
Because if the pathological tissue, like that heavy fibroid-filled uterus, is gone, the source of the problem is gone.
You would think so, right?
Yeah. The surrounding tissue should just relax. So why would someone suddenly develop new tension or pain right at that newly formed seam?
Well, we have to expand on your tent analogy to see the full picture. The pelvic floor is not a static structure. I mean, it's a highly dynamic hammock of interwoven muscles, connective tissues, and critical ligaments.
Okay.
Specifically, the uterosacral and cardinal ligaments, which previously anchored the uterus in place. So when you remove the uterus, you're extracting a major load-bearing organ.
And severing its primary suspensory ligaments in the process.
Exactly. So you are suddenly shifting the mechanical burden onto tissues that were never originally designed to carry that specific load.
Right. So the surrounding muscles, like the levator ani muscles, they suddenly have to recalibrate just to hold everything together.
Precisely. And in some patients, this structural loss just leads to muscular weakness and sagging. But in many others, the neuromuscular system registers this sudden lack of support as a massive trauma.
Oh, wow. So they go into defense mode.
Yes. The muscles effectively panic. They contract and overguard the vulnerable area to prevent anything from shifting.
Which makes sense from an evolutionary standpoint.
It does, but it creates chronic hyperkineticity, which is a state of constant rigid tension. Combine that muscular clamping with the inevitable scar tissue around the new surgical seam.
And you get an incredibly tender, painful vaginal cuff.
Exactly. The body's own defense mechanism creates a localized pain generator.
That sets the stage perfectly. So we know why the area is vulnerable. Now we have to look at what happens when the healing process at that seam actually goes wrong.
Right, because things do deviate from the plan.
Right. And how does a clinician decode the specific type of tenderness a patient is feeling to decide on the treatment? Because reading the sources, the treatments are radically different.
Night and day different. So one of the most common deviations is a condition called granulation.
Yeah, that 1998 study in our sources was wild. It said up to 34% of women experience some degree of granulation after an abdominal hysterectomy.
34%. It's a massive clinical footprint.
It really is. And reading about it, it sounded basically like a healing loop that just gets stuck. Like if you scrape your knee, you get a scab, it dries out and falls off.
Right.
But the vaginal apex is an internal mucosal environment. It is constantly moist.
Exactly. The environment literally prevents the wound from desiccating and forming a clean, dry barrier. So instead of a nice flat scar, the body's inflammatory response just stays active.
And it produces those raw, raised nodules of tissue.
Highly vascular tissue, yes. And because it's packed with fragile new blood vessels, it bleeds super easily upon contact and is acutely tender.
So if a patient comes in with this specific pinpoint tenderness and the doctor sees these raw nodules, the treatment isn't surgery, it's localized chemistry.
Yes. The standard intervention is applying silver nitrate.
The mechanism behind this is so fascinating to me. It's basically chemical cauterization, right?
That's exactly what it is. When the clinician touches the silver nitrate stick to the granulation, the silver ions instantly react with the cellular proteins in that raw tissue.
It forces the proteins to denature and basically causes those cells to die off immediately.
Right, which creates an artificial chemical scab, an Escher.
So you're forcing a scab in an environment that wouldn't normally make one.
Yes, by forcefully terminating that chaotic vascular growth, it gives the underlying squamous epithelial cells, the normal flat cells, a stable bridge to crawl across and close the microscopic gap.
That's incredible. So the tenderness dictates a highly targeted chemical burn.
Exactly. But that's strictly a surface-level tissue healing dilemma. The sources make a really sharp pivot when discussing a different kind of pain.
Right, like if the clinical inspection reveals tenderness that feels disproportionately severe for the healing timeline.
Yes. And more importantly, if this tenderness isn't isolated, like let's say the patient has a fever, or there is a persistent yellow discharge with an odor.
Okay, so the diagnostic picture shifts from a localized error to a systemic threat.
Immediately,
Okay.
you are no longer looking at stubborn granulation. The clinician is now looking at a vaginal cuff infection, which is clinically termed cellulitis.
And you definitely aren't using a silver nitrate stick on an infection.
Oh, absolutely not. The treatment protocol completely changes course. It immediately escalates to broad-spectrum oral antibiotics.
Because the vaginal cuff shares a vast blood supply and the lymphatic network with the rest of the pelvic cavity, right?
Exactly. An infection there isn't contained. It has an easy pathway to spread deeper into the pelvis.
So if it's not caught early, oral antibiotics won't even cut it. The patient has to be hospitalized for aggressive IV antibiotics.
Right.
So just to connect the dots for you listening, the specific character and accompanying signs of that cuff tenderness act as this ultimate diagnostic trigger.
It's the difference between a quick outpatient chemical swab and being admitted to an IV ward.
Wow. But as severe as an infection is, it's still a cellular issue. We have to talk about when tenderness is a warning sign for a major structural failure.
Yes, this is where the stakes get much, much higher. We're talking about vaginal cuff dehiscence.
Which is the literal separation or tearing of the surgical seam.
Yes.
The guidelines note this happens in about 0.14% to 4.1% of all hysterectomies. So it's rare, but the consequences are terrifying.
Especially following laparoscopic surgeries, the risk is notably higher.
And the detail that really stuck with me is that evisceration of the bowel occurs in up to 2/3 of all dehiscence cases.
I know. It's a terrifying statistic.
Yeah.
Evisceration means that once the vaginal sealing fails, the negative pressure and gravity of the intra-abdominal cavity literally push the intestines down through that tear in the vaginal canal.
Oh my God.
It is Quite literally one of the most acute surgical emergencies in gynecology.
So how does tenderness play into identifying a structural failure like this before it totally gives way?
Well, a full dehiscence doesn't always happen instantly. A patient might present with a sudden, sharp spike in localized pelvic pain,
Okay.
accompanied by maybe a rush of watery fluid or intense pressure. If the clinician does an exam and finds isolated acute tenderness over a tiny specific millimeter of the cuff where a single suture is failing,
Like a partial separation?
right, they might actually be able to manage it conservatively. Strict bed rest, preemptive antibiotics, and hypervigilant monitoring.
Just to see if the tissue can stabilize itself. But I imagine if it's a full tear, conservative management is off the table.
Oh, there is zero hesitation. You're dealing with exposed internal organs. The patient needs immediate IV fluids, broad-spectrum antibiotics to prevent peritonitis,
Which is an inflammation of the abdominal lining.
a life-threatening one, yes, and an emergency return to the OR. The surgeon has to meticulously inspect the bowel for any ischemic damage.
Meaning they have to check if the intestines suffered tissue death because their blood supply got pinched while protruding through the tear.
Exactly. And only after confirming the bowel is healthy can they put it back and resuture the cuff.
Wow. So dehiscence is a sudden, acute failure. But what happens when the tissue stays intact, but the support structures around it slowly fail over years?
Yeah.
The sources dedicate a lot of space to post-hysterectomy vaginal vault prolapse, or PHVP. This is where the apical ceiling of the vagina loses its support and basically inverts.
It sags down into the canal and in severe cases protrudes right outside the body. We're back to the hammock analogy here.
Right, because those primary suspensory ligaments were severed.
Exactly. So if the remaining connective tissue weakens over time, due to age or chronic pressure, gravity eventually wins the tug of war. The ceiling caves in.
And here is where it gets really interesting for our mission today. If the vault is falling, they have to sew it back up. But I saw two different surgical options in our sources. How do they choose?
What's fascinating here is how directly tenderness answers that question. The sources detailed two main surgeries: ASC, which is abdominal sacrocolpopexy,
Okay.
and SSF, which is vaginal sacrospinous fixation.
Right. So in SSF, the vaginal approach, the surgeon accesses everything through the vaginal canal, no abdominal incisions.
All right.
And they stitch the top of the vault directly to a dense ligament deep in the pelvis, the sacrospinous ligament. It sounds like a great, minimally invasive solution.
From a pure recovery standpoint, it is.
Mm-hmm.
But look at the vectors of tension it creates. That sacrospinous ligament sits deep and lateral off to the side.
Oh,
So when you anchor the vaginal vault to it, you're altering the natural anatomical axis. You're pulling the tissue backwards and to one side.
so you're anchoring a bridge straight down, but pulling it sideways to a river bank.
That is exactly the right visualization. And because you're pulling it laterally, you risk stretching or compressing the pudendal nerve branches there.
Oh, right.
Which brings us to the clinical guidelines. They explicitly state that if a woman has a prolapse, but also has pre-existing tenderness at the cuff or pain with intercourse, dyspareunia,
Yeah.
then SSF should be carefully reconsidered or avoided entirely.
Because if that tissue is already hypersensitive, pulling it sideways is just going to add mechanical tension to a neurological fire.
Exactly. It creates a persistent pain generator. So the clinician pivots to the alternative, ASC.
The abdominal one.
Right. Operating abdominally, using a Y-shaped synthetic mesh to suspend the vault to the base of the spine, the sacrum.
Which restores a natural vertical axis, no lateral pulling.
And the guidelines show ASC has significantly lower rates of recurrent pain compared to SSF. It respects the existing tissue sensitivity.
So to explicitly answer our question for this deep dive, does vaginal cuff tenderness affect the choice of treatment? It literally dictates the vectors of tension a surgeon will apply to your anatomy.
It absolutely does.
Yeah.
It's the ultimate deciding factor.
It's incredible. But we spent a lot of time talking about surgery and antibiotics. What if the tenderness is just muscular tension, tight scar tissue?
Right, the conservative interventions.
Yeah.
Because you don't always need to go back to the OR.
Right. So this is where pelvic floor physical therapy comes in. The sources recommend one-on-one muscle training, but I have to ask because I read this and got confused.
Okay, what is it?
The guides talk about using internal trigger point massage, like pressing on tender points.
Yeah.
If the cuff is already painful, isn't pressing on it the exact opposite of what you should do?
It sounds totally contradictory, I know.
Yeah.
But it comes down to the physiology of hypertonic muscles. When a muscle is locked in contraction, it compresses its own tiny blood vessels.
Okay, cutting off the oxygen supply?
Yes, creating an ischemic environment. The lack of oxygen causes the tissue to send pain signals. The central nervous system thinks there's a threat, so it commands the muscle to contract even harder.
Wow, it's a vicious loop.
Exactly. So by applying steady, deliberate pressure to that specific tender point, you are mechanically forcing the tissue to stretch.
And you just hold it.
You hold it until the physical resistance yields. As the muscle fiber exhausts its contraction, it releases. Oxygen rushes back in, and the pain signals stop.
So you're basically retraining the nervous system to stop guarding the area.
Precisely. You override the false alarm. And this neurological retraining ties into another tool, vaginal dilators.
Right, the smooth plastic or silicone rods. The guides say they use these to stretch the tissue and prevent scars from shrinking.
Yes, but introducing a firm cylinder into a tender area is daunting. The golden rule from the sources here is crucial. If you experience sharp pain, you must stop and size down.
Because you want to stretch it without the brain thinking it's under attack.
Exactly. The goal is to gently engage the mechanoreceptors, which sense stretch, without triggering the nociceptors, which transmit pain.
So pushing through the pain is actually counterproductive.
Completely counterproductive. The tenderness dictates the absolute pace of the therapy.
Wow. So what does this all mean for you listening? It means the vaginal cuff isn't just this passive, dead-end surgical seam. It's an active, communicative part of the body.
Yes, it is.
That localized tenderness means the difference between waiting it out, using silver nitrate, getting IV antibiotics, doing PT, or entirely changing a surgical plan.
And it really forces us to rethink our entire paradigm of post-surgical healing. We view surgery as the end of the road, but true healing isn't an endpoint.
Right.
It's an ongoing dialogue with our anatomy.
Yeah.
And it makes me wonder about the future. Like, what if we develop biosensors or high-resolution nerve mapping that can detect the microscopic frequency of hypertonicity before the nociceptors even fire?
Oh, wow, before the patient even feels the pain.
Exactly. We are just beginning to learn how to translate the quiet signals of the body.
And the more precisely we can read that map, the better we can navigate recovery. Thank you for joining us on this deep dive, learner.
Keep asking questions.
Yes, keep learning and pay attention to what your body is telling you. Because while the surgery might be the comma, you still possess the agency to write the rest of the sentence.